And now I would yield to Ranking Member Richmond, who is going to introduce his witness.
Thank you, Madam Chairwoman. It's now my pleasure and honor to introduce Dr. Denise Elliott, who is from Marrero, Louisiana, or who practices in Marrero, Louisiana. She's a graduate of Loyola University and Barry University of Podiatric Medicine. Dr. Elliott has served as an insurance advisor for the APMA and is a board certified by the American College of Podiatric Surgery. She has over a decade of experience as a medical specialist running her own practice. So with that, I will welcome you, Dr. Elliott, and say that we look forward to hearing from your testimony.
Chairwoman Elmers, Ranking Member Richmond, and members of the subcommittee, I welcome the opportunity to testify before you today on behalf of myself and the American Podiatric Medical Association. I commend the subcommittee for its focus on the vital issue of how the implementation of health information technology and electronic health records under the Medicare program will impact small medical practices. I am Dr. Denise Lee Elliott and a member of the American Podiatric Medical Association and Doctor of Podiatry. Currently, I am a solo practitioner and the owner of the Foot and Ankle Center in Marrero, Louisiana. I know there are members of the subcommittee who are quite familiar and supportive of the podiatric profession, but for those who may not know, today's podiatrists are physicians and surgeons licensed in the state in which they practice podiatric medicine. We are qualified by education and training to diagnose and treat conditions affecting the foot, ankle, and related structures, and provide the majority of foot care services to the Medicare population. Podiatrists receive medical education and training comparable to medical doctors, including 4 years of undergraduate education, 4 years of graduate education at one of 8 accredited podiatric medical colleges, and 2 or 3 years of hospital residency training. Most podiatrists are board certified in podiatric orthopedics and medicine or in surgery. I have been board certified in surgery since 2007. More than 65% of the podiatrists in this country practice in 1 or 2 person groups, usually employing a very small support staff and enjoying modest annual revenues, truly the definition of a small business. We face the same challenges confronted by all small businesses that must compete in marketplaces that do not always provide a level playing field. Podiatry practices and other small businesses can and do compete successfully against large businesses when the terms of that competition are fair. But success becomes difficult when the same demands are made upon large and small businesses with no consideration of the unique pressures placed on the small business. Congress is to be commended for recognizing the potential value of health information technology to improve patient care and produce efficiencies that reduce cost. Chronic diseases such as diabetes, heart disease, and kidney failure have devastating effects on patients. Many of these ailments have significant effects on the lower extremities, and the feet in particular. Inefficiencies abound in the treatment of such diseases that could be alleviated through communication and record sharing between family physicians, cardiologists, nephrologists, vascular surgeons, podiatrists, and others. Giving doctors the ability to access information on the patients they care for in real time has the potential to significantly improve the treatment and the lives of patients. At the same time, such communication and coordination should save the cost of duplicate tests, reduce emergency care and hospitalization admissions, and decrease the practice of defensive medicine. The APMA fully supports this initiative that will help podiatrists provide better care for the patients they serve. However, Congress's requirement that eligible providers implement electronic health care records for Medicare over the next 5 years places an undue financial burden on the majority of podiatrists that are small business owners. And while we are well aware of the incentive program to encourage practitioners, such as myself, to adopt an EMR program, it in no way begins to take into account the great expense that a solo practitioner will incur. I do not have access to the economies of scale that work in favor of larger practices, nor do I have the opportunity to participate in a hospital cost-sharing program. I have not yet implemented an electronic health record system in my office, although I have explored and continue to explore the possibilities. In addition to the cost, I fear the effect it may have on my practice. Typical EMR implementation takes anywhere from 6 to 8 months, and I anticipate that I will not be able to treat the same patient load during that period. To what extent will care be disrupted during the procurement and installation process? How long will it take to convert all my patient records? Will I be able to adapt to an EMR system? Will my staff? How long will it take? And while I certainly understand that an EMR system would benefit patients, will it ultimately benefit my practice? The worst thing that could happen for me and for my patients would be to lose my practice because of the cost of implementing an EMR system that is supposed to help them. It has been daunting to try to figure out where to start with the almost 300 certified programs listed on the ONC Health Information Technology product list. I am affiliated with West Jefferson Medical Center, a large hospital in Marrero, Louisiana, so I decided to initially look at a product that is utilized by this hospital. It seemed logical to me to put a system in my office that would work seamlessly with my hospital system and could potentially simplify my efforts in establishing electronic health records in my practice. But I was astounded at the cost. More than $14,000 in startup costs just for the actual electronic health record software lease. The cost for additional hardware, computers, and servers that I would have to purchase could run an additional $15,000 to $20,000. What do I do about my film X-ray equipment? I haven't yet tallied the cost to purchase a digital X-ray system that would be compatible with an EMR. All of this, I might add, at a time when Medicare is decreasing my reimbursements for radiology services and for physicians. I am also evaluating other EMR options, but am consistently learning that the software purchase, installation, and training costs run approximately $25,000 to $30,000 per system, plus additional per doctor monthly fees of up to $600. In Washington, D.C., this may not seem like a big deal, but it certainly is in Marrero, Louisiana. The current Medicare incentive program offers $18,000 this year or next year if I implement an EMR program and demonstrate meaningful use for 90 consecutive days. But it appears payments in subsequent years will be significantly delayed. At first, $44,000 over 5 years sounded like a great deal of money, but I've learned that it will not begin to cover all the costs incurred over those 5 years to become fully compliant with what is hoped to be a fully certifiable, reliable, and interoperable system. EMR vendors are currently not certified beyond Stage 1 of this 3-stage meaningful use implementation plan. In fact, vendors have only temporary certification of their software programs. What happens if the vendor and product I choose is not certified for all 3 stages? If continuing certification is costly.
Dr. Elliott,
Yes, ma'am.
I'm going to interrupt you there, but I am going to ask the rest of your opening statement will be submitted for the record, and just in the constraints of time. And I apologize for that because you are obviously presenting some very vital information. So thank you.
Thank you.